Ladies and gentlemen, I'm very happy to be here today. I'm very honored that my abstract has been accepted on this challenging topic. So, during this last decade, there has been quite a lot of literature on these topics, and it's always come from the same authors. These are the main authors which have worked on these topics, and in pediatrics, we have essentially the Texas Children's Team. So also what is very striking to see that everybody has focused on the lower limit of cerebral autoregulation, and I will try to speak today about the higher limit. So what's the idea behind? If there is cerebral autoregulation, the cerebral blood flow will be constant, maintained between these two thresholds, the lower and the upper limit of pressure. That means if statistically we will calculate a correlation coefficient between the pressure and the blood flow in this region, it will be 0, or if even negative or very slightly positive. Whereas if we calculate it in these two regions, where there is no autoregulation, the blood flow will be proportional to the pressure. So that means the correlation coefficient here will be very significant. Of course, 1 is extreme, but again, these authors who already worked on these topics have shown that if this correlation coefficient is superior to 0.4, this is already a sign that there is impaired autoregulation. The second thing is that the same team have already demonstrated that there is a very tight correlation between the NIRS signal and the cerebral blood volume. That means somewhere there is a relationship between the NIRS and the cerebral autoregulation, because the volume of the blood in the brain is dependent on the vasoconstriction, vasodilation, of course. So that means we can very easily replace blood flow by RSO2, and this relationship should be somewhere very similar. Now, our study was retrospective, unfortunately, and observational, and it included all the neonates which have been operated in our unit since 1st of March of last year. They all had corticosteroids at induction of anesthesia. They all had mildly or moderately hypotonic bypass. For cooling and rewarming, we use a pH strategy. And everybody had two RSO2 monitoring on the forehead. The bypass and the RSO2 were also recorded using a software which is available. The analysis was restricted to patients who haven't had deep hypothalamic circulatory arrest, and only to the bypass aortic cross-clamping duration. Now, how did we do the analysis? We first calculated this index. I will have a slide coming and showing exactly how it was done. We then identified those patients for whom this index was discriminant between the low pressure periods and the high pressure periods. And then we identified the optimal threshold, which allowed 75% of patients who were below this threshold not to have an impaired autoregulation. So this is RSO2 signal, and this is a pressure signal. And you can see if I have a 5 minutes window. Here, these two signals are in opposition, and indeed, the correlation coefficient is negative. If I place my 5 minutes window here, these two signals are proportional, they're parallel, and my coefficient is positive. It's very high, highly superior to 0.4. That means that for each patient, we will be able to make this kind of curve of correlation index. And if what these authors mentioned is true, we will have impaired autoregulation if the coefficient is superior to 0.4 and intact otherwise. So let's observe some of the patients we had. This is a 7-year-old boy, and he has had surgery in hypothermia. And we can see that his coefficient was quite low during all the duration of the cross-clamping. So it's very, very likely that he had a good autoregulation during this period. So this patient couldn't be analyzed because his index was almost always inferior to 0.4. This is another patient which has been operated with quite high pressures during the cross-clamping, and we can see that his coefficient was almost always very high. So probably we were too high in pressure and he had no autoregulation anymore. And you can clearly see that these two curves are almost parallel. So this is a patient who has two periods, a period where these signals are not parallel at all, and indeed his coefficient is very low. And when the pressure goes higher, these two signals become very closely parallel, and his coefficient is going up. So probably he had two periods. So this is a kind of patient we were able to analyze. And here is another one, the same situation. Pressure is low, autocorrelation probably maintained. Pressure is high, autoregulation probably impaired. Of course, the pressure shouldn't be the only parameter we analyze. We also looked to pH. We worked in pH stat, so pH was maintained according to what was indicated. SVO2s were high, so we were not hypoperfusing our patients. They were not vasoconstricted. Hematocrits were quite high. They were above the 24% threshold we were speaking in a previous presentation. And our DO2s were very high too. Remember in the work that Professor Ranucci has performed, the DO2 threshold for anaerobic metabolism was 270. Above 270, we were largely above. So this patient had a generous perfusion. So our result, a lot of patients have undergone operations during this period. Only 256 of them had complete records of everything we wanted to analyze. 58 of them were neonates, but we excluded the hypothermic circulatory arrest and those who were operated without cross-clamping. So we had 37 patients under analysis, and we have a lot of time points we were able to analyze. So most of them had transposition of the great arteries, but also other pathologies. These are their baseline characteristics, and these are the characteristics of their bypass. So you see they're very similar to the patient we just had a look previously. So in three patients we identified a lower pressure threshold. So this is very similar to what has already been reported in literature. And in 19 patients, we identified an upper pressure threshold. And the median and IQR are here. These are the patients where we could identify this threshold. I remind you that there were several patients in whom we couldn't identify such a threshold. And this is very striking because this doesn't seem to be very high pressure. And if we look to a normal pressure in a neonate, which has been, as reported in this publication, this is a normal range in a neonate. So how can we say this is abnormal if this is a normal range of pressure in a neonate? So let's look what adults reported. So this is the same methodology, the same index calculation, and these are the pressures where these index have been found in adult patients. And you can see this index is very high when the pressure is very low, 35-40 in adult is very low. it's a minimum when pressure is 60 to 70, and it becomes very high again when the pressure is 80 to 90. But 80 to 90 is a normal mean arterial pressure in an adult. So that means it's exactly the same situation than the one we just described. And those patients have been reported as having delirium postoperatively. Of course, neonates we cannot say neonates. So it may be that our findings are not exceptional. So now, of course, our work has a lot of limitations because we still don't know what effect hypothermia has on autoregulation. This is the last publication of this team in Texas Children's, and their conclusion is that today we still cannot say if they're in children, if hypothermia will impair or not autoregulation, because there are too many variables which are varying in the same direction. They could demonstrate that in animals, in experimental work, that even at very deep hypothermia, at 18 degrees, autoregulation was maintained. But well, this is in a swine model, and we cannot extrapolate it to neonates immediately. Another limitation of this study, a big limitation, is that anesthesia can impair autoregulation, and this has been demonstrated in adults that several anesthetics can intervene. So we couldn't adjust on this. And finally, one of the big limitations is that the tool we used, the RSO2, is maybe not perfect either, because the signal we have from the nerves is just a mixture of arterial and venous saturation. That means it is a reflection of not only of the DO2, but of the ratio between the DO2 and the metabolic expense of the brain. That means if you are in deep anesthesia and deep hypothermia, your MRO2 is so low that finally your RSO2 will be very high. So this is a big limitation, and probably this technology still needs refinement. So our conclusions, it is acknowledged, everybody agrees that low pressure is not good. It is likely that high pressure is not good either, and probably we have to make more studies and on a larger scale. Thank you.
Thank you very much for a very nice presentation. Are there any questions?
Joe Sestino, USA. Thank you for a very excellent presentation. When you do a calculation of the 0.4, is that 75% estimate that is correct, or what's the likelihood of having a incorrect?
Now, the threshold, I calculated it. It's simply based on a negative predictive value, which means I want to determine the pressure, which allows me to be at 75% sure that my patient won't have an impaired autoregulation.
So there's a 25% chance that it's not below that level. Okay, thank you.
Okay, I think this was our last talk, so I can hand over the token. Thank you very much. Thank you. We will restart at 11:15. Thanks.
Thank you. Please come back at 10:45.